Hello and welcome. My name is Zachary Kulov, and I'm a PMH MP student at Frontier Nursing University. And today I'll be presenting an overview of solution-focused therapy, a practical and empowering approach that helps clients create meaningful change by focusing on solutions instead of problems. Our learning objectives for this presentation will be to understand the foundational principles and applications of solution-focused therapy, identifying the strengths, weaknesses, and scope of solution focused therapy, and applying the solution focused therapy to psychiatric populations with evidence based support. Solution focused therapy was co developed by husband and wife Steve DeShazer and Enzo Kimberg in the late 70s with their team at the Brief Family Therapy Center in Milwaukee, Wisconsin. Some of the major influences were works by Milton Erickson, Gregory Bateson, and the Mental Research Institute in Palo Alto, California, as well as the philosophies of Buddhism and Taoism. Inso Kim Berg was a social worker and psychotherapist who applied this approach to work with couples and families, as well as patients with addiction. Steve DeShazer was a social worker and psychotherapist. He wrote several seminal texts on solution-focused therapy. Together, they created popular workshops, created leaders, and trained therapists in social solution focused therapy throughout North America, Europe, Australia, and Asia. The principles of solution focused therapy has a direct focus on a solution or multiple solutions depending on the patient's ability to engage in multiple goals or if they can only engage one at a time. The client is the expert because solution focused therapy is patient driven. They should have an idea of what they want as a goal. Solution focused therapy should be used with patients who have identified resources and strengths using coping que- using coping questions which are designed to elicit and understand the patient's resources. If we assume the patient has a specific goal without the means to support this through known resources, this can be detrimental to the treatment outcome. And so, getting the goals to establish these resources as an initial first step will be beneficial in engaging, moving the patient toward a solution. The patient is the expert, and we as therapists act as collaborators and not an authority. Solution focused therapy is goal oriented and future focused. And when implementing, be sure to have the patient focus on clear and concrete goal or goals that the patient can and wants to achieve. And again, we are not focusing on the past with this technique or the problem. When engaging patients in solution focused therapy, they have started the change process by taking the first step of setting up an appointment. Utilizing exceptions when using solution focused therapy, we can attempt to have the patients identify times in their life when the problem they present with was less severe or absent. When encouraging the patient to describe what were the circumstances that existed or what was different. The goal being to try and repeat circumstances that worked in the past when prompting use questions such as, when was a time that a problem could have occurred but didn't? Or similar questions to engage and identify possible solutions. The miracle question can be prompted by asking, if the problem disappeared overnight, what would be different for you? And or scaling questions on a scale of 1 to 10, 10 being the most severe. How bad is the problem? Or what would be different to you if you moved from a 5 to a 6? Would you see a difference from that slight adjustment getting better? Instead of talking about deficits, solution focused therapy focuses on what is working. Even if it's slight gains towards solutions, this will help the patient amplify those positive patterns. The strength of solution-focused therapy is in the ability of the therapist to see results in fewer sessions than traditional therapies. Solution-focused therapy is well suited for settings with time constraints and restrained resources, for example, schools, clinics, primary care. Patients are seen as capable and in control of the solution. Strength based and hope oriented focus on what is working, building confidence, reinforcing success. Due to solution focused therapy flexibility and not imposing a rigid framework, this can be easily tailored to different cultural contexts and values. Solution focused therapy can be applied across the lifespan, children, adolescents, adults, couples, and families with appropriate modifications. Weaknesses of solution focused therapy. It may oversimplify complex issues, with some critics arguing solution focused therapies might avoid deeper exploration of trauma, attachment, or systemic issues. The limits of solution focused therapy with severe mental illness makes this type of therapy less effective for patients with severe psychiatric disorders such as schizophrenia type disorders and other psychoactive and psychotic disorder categories, or those lacking insight or engagement. Patients must be able to articulate goals and engage in reflective thinking. This can be challenging for very young, nonverbal, or cognitively impaired individuals. Evidence base is growing but still limited compared to cognitive behavioral therapy. Solution focused therapy has fewer randomized controlled trials, especially in psychiatric settings. Scope of solution focused therapy. This is considered a mid range theory, not a grand theory, but more structured than conceptual model. The practice scope is best suited for short term goal oriented therapy, approximately 1 to 10 sessions, working best in outpatient settings, school based counseling, family therapy, coaching, and support groups. Solution focused therapy is less suitable as a standalone treatment for complex trauma, personality disorders, or long term psychodynamic work. Solution focused therapy can be incorporated into treatment by a varying degree of medical interdisciplinary professionals such as nurses, social workers, counselors, psychologists, and educators. Evidence based literature supporting utilization of solution focused therapy. According to evidence based literature, which supports the utilization of solution focused therapy and how effective it is in reducing behavioral problems and improve school engagement among children and adolescents. Solution focused therapy was particularly useful in school based settings, offering brief, strengths focused interventions that improved cooperation and reduced interdisciplinary action. Adults with depression and anxiety. Studies show solution focused therapy can significantly reduce symptoms of mild to moderate depression and anxiety, especially in primary care and outpatient settings. If its goal focused, empowering approach has shown an increase to treatment adherence and patient satisfaction. Applying the theory to adolescents with oppositional defiant disorder, ODD. Oppositional defiant disorder is a disruptive behavior disorder characterized by persistent patterns of angry, irritable mood, argumentative, defiant behavior, and vindictiveness toward authority figures. Populations that I chose for this: children and adolescents aged 6 to 17 years diagnosed with ODD. This affects approximately 3.3% of the US population. It affects more males than females. The ratio of 2 to 1 before puberty levels out after puberty. The socioeconomic correlation, it's higher prevalence in low income, high stress environment families. and it often concurs with ADHD, anxiety, and mood disorders. The assessment screening tools we would use to diagnose this would be the Vanderbilt ADHD Diagnostic Parent Rating Scale, Child Behavior Checklist, Oppositional Defiant Disorder Rating Scale, and also the valuable input from parents, teachers, and caregivers due to the behavior that can often occur across multiple settings. The clinical presentation and typical age of onset. Symptoms: frequently temper tantrums, argumentative with adults, actively defying rules, blaming others, deliberately annoying others, and being easily annoyed. The onset: the signs arise generally before age 8 and almost always before early adolescence. Behavior is persistent for at least 6 months. The cultural variations and impact on treatment. Cultural norms shape the interpretation of defiant behavior. Behavior, this can be a social norm in some cultures and overlooked within the family, but apparent to others outside the culture, which could be reported as being defiant. Collectivist cultures, strong independence may be viewed as disrespectful, even if developmentally normal. In Western cultures, some degree of assertiveness may be encouraged. Implication for treatment. Solution-focused therapy is adaptable to diverse cultural contexts due to its focus on the patient's perspective and cultural values. Family strengths and culturally respective goal setting increases engagement and outcome. The compare and contrast solution-focused therapy and cognitive behavioral therapy for ODD. The core focus of solution-focused therapy targets maladaptive thoughts and behaviors. It, the solution-focused therapy emphasizes building solutions and identifying strengths, focuses on client goals and resources, not on analyzing the cause of the problem. Cognitive behavioral therapy targets maladaptive thoughts and behaviors. Therapists and client identify and challenge negative thought patterns and replace them with more constructive beliefs. Session structures. Solution focused therapy is brief and future oriented, typically takes between 6 and 10 sessions with an emphasis on rapid, pragmatic change. Cognitive behavioral therapy is structured and often includes homework. Sessions typically last 12 to 20 weeks and involve practicing new skills outside of therapy. Approach to ODD. Solution focused therapy is less research for oppositional defiant disorder. Solution focused therapy can promote engagement, motivation, and strengths in resistant families, but is not problem focused and does not delve into the cause or pattern of defiant behavior. Cognitive behavioral therapy extensively researched, especially for childhood behavioral problems, including ODD. Parent training and behavioral components are often included. These interventions help restructure thought and behavior patterns that underlie oppositionality. Evidence-based, solution-focused therapy is growing but less robust for ODD. While solution-focused therapy yields positive outcomes in various mental health settings and can be effective for behavioral health, its use as a core ODD treatment lacks extensive empirical support. Cognitive behavioral therapy has strong support, especially in child and adolescent populations. For ODD, CBT consistently shows superior clinical outcomes over solution-focused therapy, particularly when including parent guidance. The philosophical orientation. Solution-focused therapy has a strengths-centric treatment. It builds on existing clients' resources and positive exceptions, avoiding pathologization. CBT, problem-centric, focuses on identifying dysfunctions and systematically correcting them. Solution-focused therapy and cognitive behavioral therapy are both widely utilized psychotherapeutic approaches, but each carries particular benefit and potential risks. A nuanced understanding of these therapies' unintended consequences is critical for safe and effective clinical practice. The benefits to solution-focused therapy is that it offers a solution and strength-focused orientation, generally posing minimal risks. Its brief, pragmatic approach typically avoids delving deeply into distressing material, making it especially useful for families adverse to pathologizing language or intensive problem analysis. But the potential harm and unintended consequences, the empirical literature is less extensive regarding adverse effects of solution-focused therapy specifically. However, potential unintended consequences of solution-focused therapy can arise if used as a standalone treatment for more severe or entrenched ODD. Solution-focused therapy may fail to address underlying dysfunctional patterns if family or child problems are more persistent, resulting in superficial or short-lived improvements. Over-reliance on positive reframing without addressing core behavior or relational issues could lead to unmet clinical needs or delays in effective intervention. If solution-focused therapy's non-pathologizing approach is misapplied to cases requiring clear behavioral management, families may miss out on empirically validated practices crucial for lasting behavioral changes. When matched appropriately, solution-focused therapy's risk profile is notably low. There is little evidence suggesting direct psychological harm, especially compared with more exposure-based or problem-focused interventions. Risk and benefits of cognitive behavioral therapy. The benefits of cognitive behavioral therapy is highly effective for a range of mental health disorders, including disruptive behavior disorders such as ODD, and it equips the individual and families with practical strategies for managing symptoms. Potential harms and unintended consequences. While generally considered safe, CBT is not harmless. Studies reveal that up to 43% of clients in CBT experience at least one unwanted side effect, including emotional distress, symptom deterioration, family strains, or new symptoms. Examples include temporary increases in anxiety, feelings of shame or guilt, or even suicidality, and relational breakups. Group-based CBT may provoke feelings of exposure to criticism or foster negative attitude towards therapy as a whole. Some clients, particularly those with lower motivational or readiness, may find CBT's confrontational aspects overwhelming, possibly resulting in dropout or relapse. And mild cases are not immune. In fact, some evidence suggests clients with milder symptoms may be more prone to experience side effects, perhaps because more serious symptoms mask these effects. Cognitive behavioral therapy's emphasis on cognitive restructuring may, if misapplied, inadvertently reinforce self criticism or lead to increased focus on problems rather than strengths. Incorrectly paced or poorly matched CBT can result in little to no benefit or even psychological harm, especially if distressing techniques like exposure is not managed with proper support. In conclusion, a psychiatric mental health nurse practitioner could benefit with the solution-focused therapy as a tool to assist patients in the appropriate setting. Solution-focused therapy offers a highly adaptable, goal-oriented, and patient-centered approach that fits seamlessly and is especially useful in settings where time is limited and patient engagement is critical. Thank you.